This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
Hi, fibrotic capsules are commonly seen in post-traumatic cataracts, especially long-standing ones in the younger patients. Now, how do we deal with this? This is one such situation wherein the patient is a 35-year-old male. Now, he has sustained a trauma about many years back, maybe about a decade back, and he's not seeing well for the last 5-6 years, and now he's come for surgery. He's got a hypermature cataract, and when we stain the capsule, the fibrotic area is very well delineated. So in the unstained picture, it's not really well identified, but the moment we stain the capsule, the extent of fibrotic area is very well delineated. Now this is the area which is going to give us problems. When we try to tear it forcefully, there is always a risk of the tear extending towards the equator. So the traditional approaches always have been to use a micro scissors and a forceps to make a nick and then work around this fibrotic area. But in my hands, that is, I feel a vitrector is a better option. So in this video, I'll be demonstrating how to use the vitrector to make a capsular opening, which is reasonably sturdy to continue with your phacoemulsification procedures. And I find it very effective and effortless to perform. I have initiated the capsular tear by puncturing with the needle, and using a forceps, the capsule is torn through the area where it is healthy until we reach the fibrotic area where we hit the roadblock, and now it is not possible to tear us. It is possible to tear it forcefully, but that can be uncontrolled and there's always a risk of the tear propagating towards the equator. So at this point, I just stop here and then switch to my vitrector. The machine which I'm using is the Alcon Infinity 1, and the cutter is the pneumatic cutter which comes with the machine. The settings are such, we require a very flow rate. I've kept it around 14 and vacuum of 300. The vitrector is set to irrigation, aspiration and then cut mode. The cutting rate which I'm using in this particular scenario is 2000 cuts per minute. This is a 23G cutter. It does help to have a newer cutter because we require a sharp teeth of the cutter so that it can be cut very efficiently. So my right hand has the irrigation, which is maintaining the chamber. The left hand, the cutter is introduced into the eye. The bevel is facing anteriorly. It goes under the anterior capsule where I want to trim. And then the foot pedal is pressed from 1 to 2 and finally to 3. So the IA cut mode. So you're going to hold the capsule and then cut it. The cut rate can be variable. If we are dealing with a very thick capsule, we have to reduce the cut rate. If the fibrotic area is not very tenacious, then we can use a higher cut rate as well. So in this case, I'm using a cut rate of 2000. Important point is to hold the cutter steady, not to be very vigorous with our movements. A vigorous movement with the cutter being on, there is always a risk of the tear extending in an uncontrolled manner. So holding the cutter just steady and slowly moving it to the adjacent area once the area which we intend to nibble is done. The beauty of this technique is extremely well controlled, predictable, and there are no surprises. As you can see, very neatly we are able to enlarge the capsular opening. The vitrector is slowly moved until the entire fibrotic capsule is dealt with. My aim is to have a capsular opening of about 5 and a 5.5 millimeter. That's what I'm trying to aim at. After completion of one span, I think I need to enlarge it a little bit more. So I'm going in with my cutter one more round. And now I think I have a decent sized opening. So if I can zoom in and show you, the edges of the capsulotomy opening are scalloped and the concavity is facing towards the center of the eye. This type of edges wherein the concavity is facing toward the center, they have a reasonably adequate strength. The regular maneuvers like rotation of the nucleus and which are common in our phaco technique can usually be withstood by these edges. So time to perform the nucleus management. The initial groove is being created. The nucleus is stabilized with my second instrument. Time to chop. Mind you, this is a very soft cataract in a young patient, so the power is going to be very less. I'm going to use just 5% phaco power, and predominantly the hold is by the vacuum itself. The nucleus is divided. The first chop is done, the nucleus is then rotated, tip is buried, the next chop is being done. When the nucleus rotation is being done, please note that I would prefer to use the bimanual way of rotating the nucleus using the phaco tip as well as the chopper. This ensures lesser stress on the bag and the zonules. The nucleus is now divided into smaller fragments, and each of these small fragments are then pulled out of the bag and emulsified at the level of the anterior capsule. And emulsifying these soft cataracts is not a big deal at all. So the most important critical step in this case was the capsulotomy, and the trick was to use a vitrector in these fibrotic eyes. Now, the posterior capsule is very much studded with Elschnig pearls-like picture. It is to be expected in such a long-standing cataract. The best way to deal with this would be hydropolish. I'm using a 26G cannula and flushing the BSS against the posterior capsule. This is going to blow out all the Elschnig pearls and loosen up some of this cortex which is adherent to the capsular bag. And then I'm going to use the bimanual I&A to just strip off the very few fibers of cortex which are still present. So once it's done, it's time to implant the lens into the bag. The bag is inflated with OVD. The planned lens, which is a multi-piece hydrophobic lens, is then placed into the bag. That's it, the case is done. Patient also has a small iridodialysis in the inferior region, and since the area is small and it is going to be covered by the lower lid, I didn't repair this iridodialysis defect. So these are the post-op pictures, and the cornea is clear, the patient is doing well. So the take-home message from this video is that vitrector is an excellent tool to deal with these fibrotic capsules. And the trick is to use a slightly sharper cutter. With a sharper cutter, you can cut the hardest of and the most tenacious of the fibrotic capsules. The only thing is you need to alter the cut rate depending upon the tenacity of this capsule. If it is very tenacious, maybe reducing the cut rate would help. Otherwise, an average cut rate of 2000 to 3000 would suffice for most cases. Flow rate should be low, vacuum should be moderate, and bevel up, hold it under the anterior capsule and start nibbling at it. It's an excellent technique which does not require any skill at all and makes the procedure very safe and predictable in such situations. Thank you for watching and hope you found this helpful.